Hello, everyone, and welcome to this third event of the Collaborating for Quality Exchange and Networking series. My name is Mary Helen Pombo, and as a policy fellow here at the Center for Health Policy, based on the 10th floor of St. Mary's Hospital, I have the great opportunity of running this very interesting series of events that we call the Collaborating for Quality Exchange, and sometimes we refer to it as the CQ events. Now, for those of you who might be new to the series, though I do see lots of familiar faces, which I'm quite happy about, the CQ started about a year ago with the help of Bob Klaber, Deputy Medical Director here at the Imperial Trust, and Kelsey Flott, our Center Manager at the Imperial Patient Safety Translational Research Center within IGHI, the Imperial Institute of Global Health Innovation. Since its inception, the CQ has really offered us a unique space to further develop innovative and evidence-based interventions that seek to improve patient safety. We've invited researchers, quality improvement leaders, and clinicians as presenters to have them share their latest innovative quality improvement interventions. At the same time, we've sought suggestions directly from our audience on how to improve those interventions best. And ultimately, we've sought to make valuable connections between the worlds of research and practice to ensure that these interventions are really transformational and not merely transactional. As an example, our last event focused on a design project that was still in development, and it sought to improve the reporting and the use of patient complaint data here at the Imperial Trust. Our previous presenter, Jackie Vandell, who was the researcher in that project, was able to take advantage of these sessions by connecting with attendees from the last CQ with patient complaint experience and looping them into the final stages of her research. While the designers of that event, Lenny and Alice from the Helix Center, took away some insights generated at our group activity, and they actually catered their design project according to that input. So we've seen that the collaboration here throughout the CQ events has really been fruitful thus far. So I want to thank you for being here today and contributing to this important ongoing conversation. Now, we at the PSTRC were particularly interested in hosting this discussion for a couple of reasons. One being that the Big Rooms intervention is an innovative and relatively newly scaled practice in healthcare, which received recognition at the BMJ Awards for its practice at Imperial and Sheffield. And moreover, we see that it's a management approach that has evidence of improving the flow of care, reducing patient harm, and improving patient experience. We're also pleased to be dedicating the session to Big Rooms as it allows us to learn from experiences at St. Mary's Hospital. And given that we have a good level of representation here, as I can see, of health professionals, researchers, and patients in the audience, we're looking forward to generating ideas together on ways to improve the impact of this technique. Now, to introduce our guest speaker on today's topic, I'll mention that our presenter, Ann Kinderlehrer, comes to us as the Associate Medical Director and Transformation Chief Clinical Information Officer at St. Mary's Hospital. She brings 12 years of experience as a consultant acute physician and rheumatologist, and was a part of the second cohort training in flow coaching at Sheffield in 2017, and has been a clinical coach of the Sepsis Big Room for over 2 years now. Now, our second presenter, Viram Jaram, comes to us as the Transformation Lead Program Manager of the Flow Coaching Academy at the Imperial Trust. In his role, he works with divisional, directorate, and trust-level leadership teams to design and run programs that improve services and outcomes for patients. His portfolio includes running the academy at Imperial, while developing staff to become improvement coaches through the Trust Coaching and Leading for Improvement program. Viram was a part of the first flow coaching cohort to join the training program. Ann and Viram, it's really great to have you here with us. Now, before I hand it over to Ann, I'll provide a brief presentation to the Big Rooms for those of you who may be less familiar with what they are, how Big Rooms have been used in the car manufacturing world, and how it's moved over to healthcare. Now, the term big rooms comes from a direct translation of a Japanese word, obeya. It was first coined in Japan within Toyota's car manufacturing company, and it's sometimes referred to as the adrenaline room, the room of war, or the brain. The big room is usually a physical room, though sometimes it's also a virtual space, which posts critical information available at the organization right on the walls of a room. It helps teams to visualize and analyze a full spectrum of information around a complex issue. Big rooms often feature graphs, updated tracking boards, and measurable indicators, which informs discussions among teams on how best to respond to the challenges they face. Teams meet on a regular basis, and the big rooms provide an environment for cross-functional collaboration, meaning multidisciplinary staff from all levels of the organization. Toyota, along with other companies such as Volvo and Timken, have used this technique to unpack the complexity of prototyping a new car. As part of the lean management paradigm, it breaks down organizational barriers. It gives staff the time and space to engage in systems thinking about the organization's latest information, and it rapidly drives problem solving to enhance product design. These meetings aim to support staff to synthesize, digest, analyze, and prioritize decisions. So why would this be interesting for healthcare? Healthcare professionals at Sheffield Teaching Hospital were looking for a way to reduce inpatient falls among older patients, while also improving their overall care experience. This healthcare issue came with a fair share of complexity and challenges, especially when thinking about how to best integrate modern technology into the scenario. Big rooms have served as an important way of engaging all improvement teams in a single place to report updates, share information, and exchange ideas. The outcome of the big rooms in this instance was an upgraded geriatric care system, which in the long run led to improved flow of older patient care and a reduction in patient falls. This meant that in 2 years' time, 8,000 older patients who had completed their acute hospital treatment were transferred to their homes at an average of 1 day's time compared to an average of 5 days' time. So with that, I'll hand it over to Jerome, who will talk a little bit more about what's to come next.
Thank you very much. So welcome everyone. We'll give you an introduction to what the Flow Coaching Academy is, what it's like being a coach, some really important work we've been doing for the last 6 months or so, looking at how we evaluate the impact of the programme. And then we'll have Kate Honeyford talking about research in big rooms and the relationship between the two. And then we'll get to try out some of the facilitation techniques that we use in the big rooms to give you a sense of what we're trying to do. So to quickly introduce sort of my relationship with the Flow Coaching Academy. I was lucky enough to be chosen about 18 months ago now, I think, to be one of the first non-clinical coaches at Imperial for one of the first franchises of the Flow Coaching Academy, which is a national programme that Sheffield Teaching Hospitals run. And I took over running the programme locally here about 4 or 5 months ago. So I'll hand over to Anne to introduce herself and talk about flow coaching.
So flow coaching at Imperial started in 2017 when 6 of us went up as 3 pairs of coaches to learn how to lead improvement for 3 pathways. Sepsis, which I coach, and you'll hear a bit more about from Kate later, diabetic foot and paediatric asthma, and has since expanded through our teaching program to 9 further pathways in 2018 and a further 9 this year with 3 pathways at Great Ormond Street and 3 this year at Portsmouth. And the reason that we brought flow coaching into the trust is that healthcare is a complex system that occurs across boundaries between systems. So starting from the community, coming through ambulance services or GP services or community services or some of our mental health pathways involving the police or social work, through hospital service and then out again the other side. So, and even within the hospital, it can involve multiple people in multiple teams. And improving complex systems is really difficult. Don Berwick, who's one of the gurus of healthcare improvement, particularly in the States, talks about the things that you need to improve complex systems. You need to know the system, you need to be able to visualize it in order to decide on what smart changes might actually result in improvement. So all improvement is change, but not all change is an improvement. Measurement over time is a really important part of what we do, because if you don't know how well you're doing, you can't know that you've improved it. And using what in improvement terms is described as a plan, do, study, act cycle, but in scientific terms is described as a hypothesis and a test, and studying the test and then refining your hypothesis tends to generate more sustainable and better improvement. Everyone involved in the system can help. Almost everybody who is involved in the system wants to make it better. Everybody who works in healthcare is there to make care better for patients. And unless you lead it, entropy wins. So the idea of flow coaching in the big rooms is to improve patient care, to improve safety, and to reduce unwarranted variation. So your systems run better and more smoothly. And the way we do that is we teach people skills in team coaching. So there's a pair of coaches for each big room. In improvement science, which is the quality improvement methods, and they bring their knowledge of the clinical pathway to the work. And the reason for that is really this. This is how it feels in healthcare. You are completely absorbed in the system, and if you were not bumping your head on the stairs continuously, you could probably think of a better way of doing it. And the way that it works is we have an 17 or 18-day teaching program for participants who come in pairs. It's action learning, so they set up their big room on their pathway or their problem somewhere between the 2nd and 6th month or 8th month of teaching. And there's an action learning set, and we teach them coaching skills, quality improvement, and measurement skills. The big rooms are designed to be a weekly or at least regular coached meeting with the two coaches in it, where we look at client voice from Toyota, which is patient story in the health service, data, principally measurement over time, to plan tests of change and then evaluate how well they work. And we teach people to look and visualize their pathway, looking at various aspects of the pathway, looking at value, however you define it in healthcare. And we teach some of the definitions, looking at essentially patient experience and outcome over cost, their vision for the pathway, their involvement of stakeholders and co-design with patients, looking at evidence, which is the measurement, and being able to visualize the pathway using tools such as process maps. And once they've assessed the pathway, they make a diagnosis, come up with an idea for change, test that with a PDSA, and eventually, after multiple cycles of PDSA, they get to standardize. And this is the roadmap for the program, where the important points are this coached regular meeting and combining data with client voice to generate themes, aims, tests of change, and standardizing care, with the idea that we can address particularly variation in data, variation in steps, variation in experience, narrow variation, and improve care. But there remains, as with all quality improvement, a very big question, which we'll come to shortly, about how we know that our outcomes are robust. But first we thought we'd try, it's actually a facilitation technique where you use an interview or fishbowl model to talk to you a bit about what it's like to be a coach. So I'm going to talk to Lydia, who's one of the first cohort of coaches that we taught at Imperial and coaches the mental health big room. So I was going to start by asking you what led you to flow coaching.
So when I started at Imperial almost 2 years ago, and I've always been quite interested in quality improvement. I'm a general manager for HIV, sexual health and infection. Good to see some friendly faces here. And I think that for me it was about wanting to do something around quality improvement, but I'd also previously done some work about managers working with doctors, in particular junior doctors, kind of earlier on in this paired learning program, which was also running at Imperial. And so for me, it was like quality improvement, but it also really appealed to me that it's kind of got that paired learning model where there's not always a manager, but someone who's from outside the pathway, and then someone who's working in the pathway very closely, working the two of them together. And I felt like that kind of continued with some of the things I was interested in.
And tell me a bit about your big room.
So the big room that I'm coaching with Barbara Cleaver, who's an ED consultant, is about mental health crisis. So it's loosely about the key aim is reducing the length of stay of patients in the emergency department who are referred to psych. It's kind of like that's how we're measuring it. But mental health crisis is quite broad, and so we have gone off into different tangents, one of which has been mental health on AMU a little bit. We're starting on that as well, and detox, and then another thing is around homelessness, just because I guess the nature of the big room is anyone can come with an issue, or because they want to change something, but often that comes from an issue. And so people kind of joined and came in who brought a specific issue. Both of those issues came from people coming to the room who wanted to talk specifically about, for example, homelessness.
And just for the room, detox is delayed transfers of care, which is one of the ways we measure people who are in an acute hospital who shouldn't be, or who could be somewhere else. What do you think are your biggest successes in the big room so far?
So I think the biggest successes have been people from different organisations who have never met each other but work quite closely together, kind of becoming, might I say, friends, or friendly. I think, mental health, especially we're an acute trust, and mental health involves so many different organisations. And a few weeks ago we had a big room focused on homelessness that had people from 10 organisations in the room, which was really first for us and quite daunting, but really interesting. And I think that there were also it's been our greatest success, but also some of our hardest conversations, because we think it's difficult within the hospital, and then when you start to involve the police, social services, community teams, everyone works so differently and has their own cultures. It's really hard to work across those organisational boundaries.
Do you have a feeling about why the big room is a good space to allow people to start to talk across boundaries?
Well, I think the most important thing, and the thing that's really important to me, is that it's flat hierarchy. I think one of our biggest successes has been the receptionist from the sort of reception team leader at Charing Cross A&E, who's called Joyce, who is a great attender of our big room. And she is now a big champion of our frequent attender care plans. And before, what was happening was that an MDT, or very experienced and professionals from different organisations, were coming up with this really complicated care plan. But the person who's literally sitting right at the front door is the receptionist. And if the receptionists don't really know or feel confident or feel the value of the care plans, really what was the point of 6 or 7 professionals working out this beautiful care plan if they're not going to be enacted by the first person? And I think that what happened was we had quite a difficult conversation in the room between different people about, it was really about what was perceived to be chucking people out of the emergency department who are coming. There's people who are attending more than once a day, and their care plan said that they should be accessing their key worker, or they have other social support, and that they shouldn't be admitted to the ED. But that wasn't being followed through from the receptionist. And we had a quite heartfelt conversation from the receptionist saying, I don't come to work to chuck people out. If they're coming to ED, then what am I here for? I'm here to let them in. They're obviously coming to the emergency department for a reason. And the psychiatrist explained how that person was actually under a psychiatrist and having a lot of intervention outside. And it was actually part of their treatment plan that they do not come to ED. And it was actually helping them to not come to ED. And no one had explained that to her. And she was being incredibly caring and doing absolutely what we expect the trust values are. But it was like that conversation really changed things. And now she's like one of the most passionate people about care plans. And she came to St Mary's to talk to the reception team about care plans. So I think there's been different.
So it's a space that allows us to implement design that may have happened outside the big room or happened before, but allows you to actually make it happen because you've brought the stakeholders together.
Yeah, in like a real way. not just like people talking about something that then isn't going to happen. Having said that, it's really hard for us to get A&E doctors and nurses in the room. So like it's great to have Joyce from reception, and we will often have like the alcohol liaison nurse, but like in terms of a charge nurse, in terms of people who are really triaging mental health patients, it's difficult.
And that, I think that's an issue for all of us, isn't it?
Yeah.
In that any non-elective pathway, so any emergency pathway, you're quite keen to have A&E represented, but actually pulling people off the shop floor to do improvement work is difficult. And so the sepsis big room, where A&E is a really big stakeholder, we nearly always have a consultant from A&E, but getting other people we have to plan in advance and work around.
Yeah. And the other thing that's been challenging is having patients in the room, I guess because it's mental health crisis. There's lots of people who are active in patient representation in mental health in the community and in mental health trust, but less so in the acute trust. But we do always have a patient story, but told normally by a staff member.
And that's an approach we've adopted in the sepsis big room as well, but actually is one that I want to rethink and to start to think about how we can have novel ways of bringing patients into the room and finding patients who presented with an acute condition or an acute crisis and then moved on, bringing them back so that they get to be part of designing a service that works for them. Do you have measures that show outcome from your big room?
We have some measures that we are measuring. Haven't shown an improvement. Length of stay in the ED for mental health patients is 5 hours at St Mary's and 7 hours at... Sorry.
Median length of stay.
The median is 5 hours at Charing Cross and 7 hours at Mary's.
Which, given that I know that at least one of the outliers is 44 hours,
Yeah.
does mean that you have some very short, I suspect.
Yeah, yeah, and also not everyone who's referred to psych is in a mental health crisis. They could be in for another reason, but that's just like what is easier data to pull off a Cerner, basically. But that's important as well to have like easily accessible data that we're measuring. That's like our main measure. Patient experience has got a lot better because we helped to design this new mental health room at Charing Cross, and there's quite a lot of interviews that have been done through this architect who's working in mental health design about how it's much better. So there have been some outcomes, and care plans have expanded. So the number of care plans that we have and the number of attendances for those who have care plans, which are high intensity users, their number of attendances have decreased. For some specific patients, like an insane amount, like 70%.
Amazing.
Yeah. So really, there's some specific things that have gone really well, but overall length of stay hasn't decreased yet. But then again, length of stay of mental health patients in the emergency department is a huge problem.
National crisis.
And if people hadn't have sorted it, people would have sorted it by now if it wasn't a really complicated problem. So I wouldn't really expect in 6 months for us to have those kind of results. I think what's really good about the big room, for example, now there's this new compact for mental health patients where there's an agreement that they should all be admitted in their local trust, more like kind of physical health acute trust work. And the big room has become a place where we can talk about that, and it's become like more part of the structure. It feels like mental health has a bit more of a place now to go, whereas before I don't think mental health did really.
And that's a big part of the big rooms, isn't it? It changes the culture of, particularly where you've got so many organisations working together.
Yeah.
And it's all about engagement, and
Yeah.
none of it's about design and then buy-in.
Yeah. And a lot of that engagement also comes, maybe for us, has come first sort of from education. So we put on some education days, just like mental health education day, and 50 people came and it got really good feedback from all sectors. And that was a way that then we had more people coming to our big room because they were more, the education was appealing, and then they became more involved in the quality improvement.
Amazing.
It's been fun.
And if you had one wish, if you had a magic wand that could guarantee you one wish for your big room, what would it be?
it would be for ED to be quiet every Tuesday between 1 and 2 p.m. so more people could come, I think, would be my wish, yeah.
So you've heard a little bit about what it's like to be a coach in a big room and some of the specific things the mental health big room has done. We've been doing some work in 2 different ways to be able to evaluate what we actually do at the big room. Viren's going to start by talking about some work we've done to look at can we assess a return on investment for the cost of teaching and running the big rooms. And then Kate Honeyford, who's a Imperial College researcher in my sepsis big room, is going to talk about some of the evaluation about what we've actually done in the sepsis big room, what that's like to be a researcher in the big room.
Thanks.
How do you know the things you're doing actually make a difference? So this question we were asked about 8 or 9 months ago by the organisation as a whole. We have a thing called the Richard Alexander test as an organisation, which occasionally appears. He's our CFO and often asks this question. As you can imagine, at a time when we have a few very large programmes like this, the Trust's financial position is similar to the NHS's financial position as a whole. And so what we've been doing for around the last 6 months is working with the Evidence Centre, who support the Health Foundation evaluating off of their programmes, to come up with a framework for us to use in the way in which we evaluate our improvement programmes. So what we'll do is talk to you about the framework and some of the things that we found through that. So this is the overarching framework that we use, and we're looking at what the impact is in 5 different ways. So firstly, what's the impact on the quality of patient care of the changes that we're making? What's the impact on the staff who are in the big room, the staff beyond the big room itself? What's the effect on the culture of the organisation? So the way in which the improvement team sort of thinks of itself is there to create a culture of continuous improvement. So this is a large part of the way in which we think about what the impact of what we do is. Next, what's the value for money of the interventions that we're making? And what's the impact on the wider system? So beyond the room, beyond the trust itself. I think Lydia's big room is a really good example of having lots of different organisations coming together. What's the impact that we're having on the wider culture of the health and care system, effectively? So I'll delve into 3 of these just to give you a sense of the types of things that we've been looking at and the sort of approach that we've taken. So what's the impact beyond the quality of patient care? This is just 4 examples. The top 2 are from big rooms that have been running for a couple of years. The bottom 2 are the big rooms that started last year. So we've seen a reduction in mortality in the sepsis big room. Okay. We'll cover that in a lot more detail than we've got here. The paediatric asthma big room, one of their sort of most important aspects is the empowerment of the children, their parents, and so having a written care plan, written management plan for their asthma is a really important thing to make sure that parents know what to do. And what they've seen is an increase from 25% to 60% of patients having written management plans when they leave. It's been pretty amazing. And that's not just happened from 1 or 2 small changes. It's been something that's taken, I think, it was about a year in total to get to that position, and they're starting to see further improvement since then. The vascular big room has seen a 50% increase in their discharges per week. So Laura sitting at the back is the coach for that room. And recovery, Dave's here as well, it's great, has massively reduced the number of overnight stays per month at St Mary's. That's been a really large change in sort of taking something that was normalised behaviour of having patients overnight in an area they shouldn't be, and turning it back and sort of making it something that's abnormal again. When we look then at the impact on staff, we've looked at 2 particular aspects. So what's the impact on the staff in the big rooms and the coaches of using QI tools themselves? And what we've seen through the work we've done, and that's primarily through interviewing people who are actively involved, people not very actively involved who are on distribution lists for the big room as well, is that the big room itself has improved the confidence of staff using quality improvement tools and techniques. So that's not only the coaches who are supported by the 18-day training programme, but the weekly big room has an impact on the people who come. And the safe environment has allowed them to build their own confidence in the tools. What we also see beyond that is that the people who come to the big room are then confident to help others with improvement. So the people who are being coached in that environment then go and help others coach others to make improvements themselves. And a lot of, I think the thing that's been most heartwarming running a big room myself is seeing people use the tools, techniques, come back to me and ask me questions about the way in which they're coaching someone, rather than it being them just doing the improvements themselves. So the last one I wanted to look at was value for money. I'll hand over to Kate. We've been very generous in the way in which we think about the costs of running the programme, and then very stingy in the way in which we've thought about the impact the programme has had. And that's both in the way in which we've defined value, which has been focused on things that you can put a return on financial value against, rather than looking at potentially things like the impact on patient experience, or even things like turnover rates for particular staffing groups. And what we can see here on the left-hand side is that the cost of the programme for 1 year is approximately £670,000. So that includes people coming to the weekly big rooms. That includes the training days we've put on, the time for faculty, the time for the coaches. Also includes the cost of the rooms that they're in. And on the right-hand side, we see the impact of the changes that have been made. So the diabetic foot big room has seen a reduction in its length of stay. And that saved the equivalent of about £350,000 worth of bed days. Similarly, with elective vascular surgery, that's seen a reduction in their length of stay, saved £380,000 worth. When we look at the recovery project I mentioned, that's reduced the sort of implied cost saving through the increased cost of providing that type of care has been over £1 million. So it's been quite extraordinary, actually, in terms of the direct impact we've seen of the changes that we've made through the big rooms. So I'm going to hand over to Kate, who's going to talk about what it's like to be a researcher in a big room.
Thank you for inviting me. So I'm a statistician at the Global Digital Health Unit. I'm just going to use the keyboard because I'm scared. In the School of Public Health at Imperial College. And I thought I should start off by saying I'm funded by the BRC, so I'm funded through that kind of initiative. And I recently gave this talk at a conference called Sepsis in Seattle, and I'm currently responding to reviewers' comments on this paper. And I guess I just wanted to start off by highlighting in collaboration with, we have the Sepsis Big Room on the paper, they are listed as an author, because without them, the research wouldn't be of the quality that it is. And obviously there are lots of other people who've contributed as well. So I'm not going to discuss the methodology here, but what I am going to say is that sort of working with Anne and the big room enabled me to do a really robust statistical evaluation of the introduction of a digital sepsis alert at the Trust. So that was introduced through the Sepsis Big Room. The Big Room did the kind of the PDSA cycles to introduce it in stages, to get feedback, to improve it. And I was able to access that data through a license to attend and various other aspects, and be able to do an evaluation using sort of nice statistical methods to show that we have a lower risk of death associated with the introduction of the alert of 24%, a lower risk of extended length of stay, and an increased chance of receiving timely antibiotics, and that's IV antibiotics within 1 hour of the alert, which was the target set by the Sepsis Big Room. Working with the Sepsis Big Room enabled me to exclude certain patients that the alert maybe wasn't appropriate for, and make those targets make sense to the people who were responding to them. So, working with the Big Room, it's been a really, really interesting experience, and I get to hear what clinicians think of my analysis on a weekly basis. So if you're a researcher, you might be used to having meetings regularly, but I doubt you have them weekly. And this is a photo of a big room, and as my daughter always says, but it's not a big room. You know, I think that is worth bearing in mind. Not all the comments are constructive. So I quite often hear, that's not my experience. Or, well, we knew that anyway. Or, I just don't believe it. That comes up as well. In addition, what's brilliant for me is they say, have you thought of it like this? So I've just got kind of this data. I've got columns and columns and rows of data. And people can say to me, have you thought of it like this? They can say, well, this measurement will answer it for you. I'm not a clinician. I don't understand a lot. But they can say to me, that's the column you should be interested in. And they can also say, which is really, really interesting, this is how the data is entered. So when we're looking at timestamps, people can say, yeah, we don't always enter that as we're doing it. Or, oh, maybe it happens more like this in this ward. And that is really useful. And then magically, sometimes people will say, well, that was really interesting. Imagine that if you're a researcher in the room, you'll know how amazing that is. The other lovely thing is it constantly informs the next step. So I'm in a really nice position that they've extended my funding, I can do some more research, but I can have that guided by the people in the big room on what they're interested in. So optimising the alerts is massive, appropriate antibiotic prescribing rather than just antibiotic prescribing. Alerts for maternity patients. There's a lot of interest in the difference between Charing Cross and St Mary's ED performance that we look at on a weekly basis. Can we use routine data to understand that? And there's quite a lot of interest in who dies of sepsis. And I think it is really nice for them, dare I say it, to have a statistician in the room. I don't know what all the words mean, and sometimes I have to ask them quite odd questions just so I can keep up with what's going on. Sometimes I'm completely flabbergasted by some of the things that happen, and when I say that, people go, oh, yeah, no, that is a bit odd, actually. We're just used to it. But I think it's also really nice that I can say, I don't think that can be a median, because it just doesn't make any sense. If that's the median, maybe it's the mean. And so when the data is presented on a weekly basis, I think it is, I don't want to kind of say it's perfect, but I think it's quite nice having a statistician in the room who knows the data, who goes weekly, so I get a really good feel for the discussion of the data. I try not to just drop in, obviously. And I do take notes regularly for them, so I do try and contribute in that sense. And I think it's really odd to finish on a quote from myself, but I'm going to. It has been a really amazing experience sitting in the big room, having my research informed on a weekly basis. It's completely remotivated me to do research and to feel that it has kind of a possible benefit, that it might actually help patients have outcomes. And listening to discussions about what the data actually means to people who care for patients and how sepsis QI initiatives, including the alert, work in wards, just listening to that every week has just given everything a much, much more interesting meaning and put it all into context. So anyone who's interested in the actual research, I'm really happy to send you a link and to talk to you. There you go.
So a really large part of the way in which we run big rooms successfully, I think, is sort of under the banner of team coaching. And that's one part of that is how do you coach room, ask good questions, and sort of more traditional coaching aspects. Another part of that is how do you facilitate lots of people in a room so that you can get the best out of a group of people rather than it just being kind of what this is at the moment, which is lots of information in one direction. So there's this thing, organisation called Liberating Structures. Hands up those who have heard of Liberating Structures, used Liberating Structures? Yeah, that's pretty good, it's not much. So this is kind of the idea behind what liberating structures are. And so we think about two things. One is how much people control the content, or how many people are controlling the content of what's going on. So what we're trying to do is basically get to the opposite of what's happening right now at the presentation. So we want everyone in the room to control what the content is of what's being discussed, and also then shape what's actually happening and the actions that people take. So rather than it being sort of just unidirectional in terms of information, what we try and do is bring as much as we can out of the people in the room So that may be about how best to spread ideas, generating ideas. It might be understanding a problem in a deeper sense. All those things are better done as a group rather than an individual trying to do that thing. And so what we'll do for the next sort of 40 minutes or so is try a couple facilitation techniques that we use in big rooms so you can get a sense of what it's like to be in one. And then what we'll do afterwards is distribute a list of all the big rooms that we have, so you can, if it aligns to a research area, that would be great. Otherwise, just go and do it because it's interesting. The idea is to sort yourselves into groups of 3 and 4, like in those pictures. So you get yourself into a small group. One person picks a problem that they have. They spend a couple of minutes describing what the problem is. The other people in the group can ask them clarifying questions for a minute, and then they turn their back from the rest of the people. The rest of the people then discuss the problem, think about potential ways that they might solve it to inform the other person. So they don't contribute at all in that sort of 3-4 minute bit afterwards. The idea is that they effectively give the problem to that group to discuss and use their ideas. Does that make sense to people? Fab. So we're going to try it now as a group. So I'm just going to throw out the room. How do people find that?
Yeah, I really like the experience of being able to listen without having to respond. I always like those things. So you've got because normally you're listening to respond, aren't you? But you're not allowed to, and it gives you a real freedom.
I find it really constraining the first time I did that for exactly that reason.
Different personality.
So the next technique we're going to try is a way of using a facilitation and discussion technique to come up with ideas and then to, as a group, rate those ideas and work out what the top ideas are that we might be able to put into action. And what we thought we would take as a problem from this, so that we get some actions from this CQ event, was how can we better bring together academics and big rooms? So how can we better bring research into big rooms and evaluate what we're doing and use big rooms as a space for researchers to be able to bring ideas and test pilots? So what we want you to do to start with is to spend 2 minutes thinking on your own and then write your best answer to that question. If you were 25% bolder, if there were 25% fewer constraints, what would your best idea be for how do we bring academics into big rooms? Or research into big rooms, or combine what we're doing in big rooms with translational research and safety research. In this 2 minutes, write that on your index card. One idea on one side of the card. If you already work in the quality improvement space, it might be something that you want for your big room. That's fine too. What kind of research would most help you in your space, and how might you get it there? Okay, what we're going to do now, I'm going to quickly demonstrate to you with Vasiliki. What we're going to do first, to mill around, and all you're doing is swapping cards. Everybody needs to keep one card and one card only in their hand at all times. You're just trying to swap cards so that you've read as many cards as possible. At the end of that 3 minutes, I will stop you, pair up with somebody, and discuss briefly for another 2 minutes the ideas you are on that card. At the end of that 2 minutes, I want you to score them out of 5. So 1 is, you could not implement that idea if you had £1 million and a magic wand. And 5 is, I have no idea why we haven't done this already, we need to do it immediately. So that's your scale. From couldn't be done with a magic wand to need to have already implemented this. So from 1 to 5. Yeah, yes, feasibility and desirability, both of those. And the idea is thinking about ideas into action. So it's about how would we actually do this. And then we'll try and do that for 3 more rounds. So 3 more rounds of 2 minutes milling about and exchanging cards, stopping, discussing them for 2 minutes and scoring them. At the end of that time,
you will have 3 numbers and 3 numbers only on the back of your card. And then we will go around the room seeing how many have scored 15, 14, 13 and so on, so that we can generate the top 5 ideas. Make sense? Everybody stand up. Worked really well in our big room. Not scoring it yet, you're just exchanging the cards with as many people as possible. Try and read as many cards as you can in this phase. All right, stop and find a partner. Now, what you don't need to necessarily exchange. When you've found someone to pair up with, read what's on your card to them and have a brief discussion. You're not yet scoring. You're just discussing what's on the cards. You've got 2 minutes.
Don't find a partner, go and join a 3.
You can always join a 3.
Make it 3.
Now what you need to do is individually score on your card on that scale, on the back of your card, for the idea that is on your card on a scale from 1 to 5. At the end of this, you should have 1 number and 1 number only written on your card. And when you've done that, we have another round of circulating around the room, swapping cards. So try and swap your card with as many people as possible. Looking at the room, I think most people have seen most cards, so find a pair. So find a pair. If you can't find a pair, find a 3. And discuss what the idea that's on your hand and what you think about it. Once you've finished discussing your card, then you should score it again on the same scale. You should now have 2 numbers written on the back of your card. Has everybody got 2 numbers written on the back of their card, apart from the ones that don't? So we have one last cycle of milling around the room, swapping as many cards as you can. The idea is that everybody should have seen every card, so that's what you're aiming for. Just swapping cards as quickly as you can to make sure that you've seen every card. Same scale as before. At the end of this, everybody should have 3 scores on the back of their card. Right, has everybody got 3 numbers written on their card?
Yes, everyone got 3 numbers?
If you don't have 3 numbers, divide the number. So, find the mean of your numbers, i.e. add them all up and divide them by the number that there are, times it by 3, and that's your total score. If you have 3 numbers, just add them all together. Make sense? Anybody not have 3 numbers? How many have you got? 2. So, work out the mean and times it by 3. And the rest, everybody else is adding their 3 together. Has anybody got a card with 15 on the back of it, which is the highest possible score? Anybody 14? What's your idea? That sounds like a really good idea. Anybody volunteering from the academic side to help organise it? I'll pick that one up and see who we can find to help.
I think that was a yes.
Yeah, I thought it was a yes too. I definitely heard a yes. I thought there were some people that I might be able to volunteer in that space with some help. Brilliant. So that was 14. Anybody got 13? 12?
Qualitative research, obtain funding for a PhD student, leave them with time on a dedicated role.
To evaluate the big rooms. Is that the...
It just says qualitative research, obtain funding for a PhD student.
Anybody got any ideas how we might turn that into an action that we could?
Yeah, I mean, we chatted a bit on the related to who are these researchers you'd invite to the speed dating. So the people doing rather than PhD, the people doing masters need projects, and so masters and MPH students. If we get our timing right, that would be a brilliant event to do for the speed dating. Yeah, BSc as well. And they're there and they sort of hit for that few months of the sort of, they need to do it over a sort of time period that would be helpful to do.
Yeah, I've got three coaches, clinical, non-clinical and researcher.
Ooh, there's an interesting idea. Is that something we could do for the next cohort? That's a really good idea.
Or could you just have your non-clinical coach be a researcher?
That too.
And this brings to looking at there was some about action research and things that happen. That would be your enabler to do that.
Mm. 11.
There's 11 here that I think links to somebody. So it says find the relevant data to measure the outcome. Invite a researcher along who has data skills to help you make sense of the data. So I guess it's connecting up a question with data and a researcher would be able to help you summarise on the PowerPoint slide. Connect a question with data.
So I'm going to, as the researcher who's been using the data, say, I guess, one of the actions that maybe...
To iterate that.
Has anybody got an idea on a card that hasn't scored in that top 4 ideas but they actually thought was brilliant? There's a moderation piece here. And we'll collect all the cards in, so nobody's ideas and
wasted. Really well, you don't.
Amazing. Thank you all very much. If we can collect all the cards in, then we don't lose anybody's ideas.
Thank you again to the speakers and thank you for joining us. I hope that you'll all enjoy a little bit of wine and some cookies that are left after all the hard work that we did with these group activities. Thank you again for coming.